Pain is not a mistake. It's actually a biological necessity. Think of pain as your primary sensory system for protecting your tissues. Its main job is simply to keep your body running safely. This safe balance is called homeostasis. Pain tracks down anything that harms you and points out the danger immediately. Plus, pain is an absolutely essential tool for doctors. The exact location of your pain gives them vital diagnostic clues. It helps them figure out exactly what's wrong inside your body. Pain is highly unique. Why? Because it's actually two distinct things at exactly the same time. First, it's a physical sensation. This sensation tracks the exact tissue damage. But second, it's an emotional feeling. Any medium or high-intensity pain automatically triggers intense worry. It creates a powerful physical urge to escape the source of the harm. You really cannot separate the physical injury from the emotional anxiety. They are locked together. Sudden acute pain instantly wakes up your entire body. It triggers a very visible survival response. We can remember this response with the acronym BEDS. B is for blood pressure rising. E is for elevated stress hormones, specifically cortisol. D stands for dilated pupils, meaning your eyes actually get wider. And S is for swift heart rate, meaning your pulse beats much faster. This is literally your body preparing to survive an immediate threat. Moving on to section 1, focusing on peripheral mechanisms. Your body has primary responder nerves. These are called primary afferent nociceptors, and there are three main types. First, we have A-beta fibers. These are thick and well-insulated, so signals travel super fast, but they only sense light, gentle touch. They don't normally send pain signals. Next are A-delta fibers. These are thin but still insulated. They send fast pain signals. They are triggered by sharp, intense, immediate hurts. Finally, we have C fibers. These are thin and completely uninsulated. Because of this, they send slow pain signals. C fibers are triggered by slow, throbbing, intense hurts. Now, these nerve endings are activated by specific triggers. One major sensor is the TRPV1 receptor. This is a specific receptor on your nerves that senses dangerous heat. Think of it like a biological lock and key. And this leads to a really fascinating fact. TRPV1 is the exact same sensor triggered by capsaicin. Capsaicin is the chemical that makes chili peppers taste spicy. So your body actually interprets spicy food using the exact same alarm as literal physical fire. When tissue is damaged, it gets inflamed. Chemical agents flood the area, and they lower the nerve's alarm threshold. This makes the nerves hyperreactive. We can track these chemicals with the acronym ABS, pain. A is for ATP, which is released from broken cells. B is for bradykinin, a chemical that causes severe irritation. S is for serotonin, which triggers local sensors, and P is for prostaglandins. Prostaglandins make all nerve endings extra sensitive. This massive chemical flood is exactly why normal movement suddenly feels highly painful. Section 3. Traveling to the brain, looking at the central pathways. Let's trace the exact physical journey of a pain signal. First, the signal enters the spinal cord through the back door. This specific area is called the dorsal horn. Fast signals use a chemical called glutamate here. Slow signals use peptides like substance P. Next, the signal crosses over to the opposite side of the spine. From there, it travels straight up the spine of the thalamic highway. Then, it reaches the brain's sorting station, known as the contralateral thalamus. Finally, the signal splits apart and travels directly to the outer brain cortex. The crucial point here is that this pathway can malfunction. If pain nerves constantly fire into the spine due to long-term inflammation, the spine actually changes. The receiver nerves inside the spinal dorsal horn become hyper-excited. They literally change their fundamental programming. This causes a clinical state called allodynia. What is allodynia? It means that completely harmless touch, like the light brush of a shirt, suddenly feels painful. The whole system becomes completely oversensitized. Once the signal reaches the brain, it splits. The brain maps the pain into two distinct categories. Let's use the acronym SACI. S stands for the somatosensory cortex. This region handles the purely physical aspects of the sensation. It tells you exactly where the pain is and how strong it is. C and I stand for the cingulate and insular cortex. These regions handle emotional suffering. They dictate how much the pain bothers you and how you behave, so your brain processes physical location and emotional suffering in completely different areas. It uses natural chemical painkillers like endorphins, and your psychological mindset physically changes this volume control. Consider the placebo effect. If you strongly expect a treatment to help, your brain triggers its internal opioid system. It literally blocks the pain signals. Now consider the opposite, the nocebo effect. If you expect pain to get worse, your brain actively amplifies the pain signal. Your expectation directly dictates the physical volume of your pain. Sometimes chronic pain stops being a warning sign. It actually becomes a standalone disease. A key example is complex regional pain syndrome, or CRPS. This is a severe condition. It features constant burning pain and massive swelling. It occurs because the automatic stress system gets permanently stuck in overdrive. The nervous system remains totally altered, even long after the initial injury has fully healed. When your actual nerve fibers glitch or become damaged, it causes what's known as neuropathic pain. Doctors diagnose this specific type of pain using the acronym BEST. B stands for burning sensations. E stands for an electric shock feel. S stands for sodium channel density overload. Basically, damaged nerves grow too many sodium channels, which causes spontaneous electrical misfires. And T stands for tingling or pins and needles. This is the treat pain, focusing on pain management. Let's talk about treatments. First, we have non-opioid medications. COX inhibitors, like NSAIDs and acetaminophen, block COX enzymes to stop pain chemicals at the source. But NSAIDs carry risks of stomach, kidney, or heart issues. Acetaminophen is safer for the stomach, but high doses can cause severe liver toxicity. Next, we have antidepressants. Doctors actually use very low doses of these to balance brain chemicals and soothe nerve pain. Finally, anticonvulsants. These act as a first-line treatment. They are very effective at calming down overactive nerves. Opioids are the heaviest clinical hitters. They directly lock onto mu receptors in the central nervous system. This immediately shuts down incoming pain signals. They can be administered through IVs, pills, skin patches, or epidural spinal injections. In hospitals, safe delivery is often ensured using patient-controlled pumps, or PCA. The patient presses a button and a computer delivers the exact safe dose. However, long-term use carries massive risks. This includes high tolerance. It also includes opioid-induced hyperalgesia. That's a strange condition where opioids eventually make the body even more sensitive to pain over time. Modern pain management also requires targeted helper drugs. We can categorize these with the acronym GANM. G stands for gabapentin and pregabalin. These are nerve-calming anticonvulsants. A stands for antidepressants, used here strictly to soothe long-term pain pathways. N stands for naloxone. This is the emergency rescue blocker. It's used instantly to reverse life-threatening slow breathing from opioid overdoses. And M stands for methylnaltrexone. This is a highly targeted blocker. It only stops opioids in the gut to prevent severe constipation, without ruining the pain relief up in the brain. When managing long-term pain, the clinical philosophy really has to shift. The main goal in chronic pain care is realistic improvement in daily functioning. The goal is to sleep better. The goal is to return to work. The goal is not expecting the pain to drop to absolute zero. Evaluating mental well-being and focusing on daily life function is the absolute priority for patient recovery. We've seen exactly how pain operates.